Okay, good morning, you guys. Thanks so much for coming. Today we're really excited to have Dr. Susan Merel come and talk to us. She's going to give us a great framework for how to approach inpatient management of pain, which I think is can be really hard. So I think this can be super helpful. Dr. Merrill is both a palliative care doctor and an inpatient medicine doctor working up at UW. So she works both on service as a hospitalist with the residents and then also in palliative care. And then she also is a great medical educator and runs the sub-I clerkship up there. Tweak me if I missed anything. And
That's great. I do palliative care consults at Harborview too. The MICU interns might recognize me. All right, welcome. It's truly an honor to be part of this series that's been handpicked. If people are in a place where they can turn their cameras on, I would much appreciate it. Honestly, I feel like I do a better job when I can see some people's faces, but if you cannot, that is fine too. I can see the chat, so everyone can see my screen and hear me okay? Okay, and see the slides? All right. I have both the chat open and I can see your boxes. So I'm going to go ahead and get started. There are going to be poll questions. So if you are in a place where you can access the poll, that would be great. Here's my obligatory disclosure slide. Nobody bribes me to take care of old people and people with pain. You have probably gotten this call, right? Here's this patient you've never heard of. He's having a lot of pain. I gave him a bunch of opioids. He's asking for more pain medication. Can you do this? Like, it's no big deal. And it might have made you a little bit anxious, and that is totally normal. So my objectives are to describe an approach to pharmacologic pain management in hospitalized patients. We're going to practice opioid choice, titration, and conversion. We're going to talk a little bit about opioid side effects, opioid withdrawal, and then best practices in pain management near the end of life. So I'm going to go relatively quickly to cover it all. The slides will be available at the end. I am not talking about the chronic use of opioids for chronic non-malignant pain, right? The opioid epidemic is very obviously real and a problem, but it should not keep us from prescribing opioids appropriately for acute pain in seriously ill inpatients or outpatients for that matter. So let's jump right in. Our first patient is Mrs. S. She is having 10 out of 10 right hip pain, and she's been getting Tylenol, and it is not working. So here's your trusty sign out. She's a watcher. She's 85. She had a hip fracture. She's going to the OR in the morning. She has some hypertension and some CKD. Here's her meds. People are worried about her getting delirious, and they want you to avoid CNS active meds, and she is full code. So you go see her. I'm not really supposed to say that older adults are cute, but some are cute. Let's just say she's cute. And she is a little hypertensive, but her vital signs are otherwise okay. She is frail appearing. She is talking to you. She is not delirious. She is uncomfortable. Her pain is from her hip fracture, and her creatinine is 1.3. So first poll question. What order would you write to improve her pain control? Would you add ibuprofen? Would you stop the Tylenol and start a combination product? Would you add oxycodone, 2.5 to 5? Would you add morphine?
we're getting some results. Thanks, guys. Okay.
Great. Okay. It always makes me happy when at least one person picked, or at least a couple of people picked every choice, because it means that I didn't make the question too easy or too hard. So most of you picked what I consider the best answer, which is oxycodone, 2.5 to 5 milligrams every 4 hours. But people did pick the other choices. So I am going to talk about that. So my first teaching point here is about non-opioid analgesia. So Tylenol or NSAIDs in some circumstances can augment opioids. So we don't stop the Tylenol or acetaminophen when we start opioids. And I would consider scheduled acetaminophen in this patient. I do avoid NSAIDs in older adults because of the high risk of renal failure, CHF, and GI bleeding risk. I generally don't use NSAIDs in inpatients very much, again, because of renal failure and bleeding risk, even in younger people. I use NSAIDs occasionally in somebody who's usually a younger patient, good renal function, clearly inflammatory source of pain, like someone with cellulitis who's younger. But don't use them very much in older adults, which is why I didn't pick that answer. I don't use combination products in the inpatient setting. Those are really intended for like when I get a painful dental procedure or bump my knee when I'm camping and need stitches, and I take just a few of those for a couple of days and they make me throw up, and then I stop and I'm done, right? Those are not something that I use in the inpatient setting, because people who are inpatients have enough pain that we need to be titrating both components. And in addition, we want to be careful with those in general because they often contribute to unintentional acetaminophen overdoses. So in this patient, I would consider scheduling acetaminophen, and I would start a low dose of an as-needed oral opioid. For example, 2.5 to 5 milligrams of oral oxycodone every 4 hours as needed. And I'll get into this in a little bit, but the reason why the morphine is not correct is that is too high a dose for her age and renal function, and morphine IV lasts about 30-45 minutes, so it would knock her out, and then she would wake right up with pain. All right. I'm looking at the chat. I don't see any questions, so I'm moving on, but feel free to throw any in there. In terms of her sign out, and somebody said, avoid CNS active medications. That is correct. And opioids are CNS active. But pain can also be a strong risk factor for delirium. And if an older adult is in too much pain to get out of bed, bad things happen, right? They lose function. They end up in a nursing facility when maybe they wouldn't have ended up there otherwise. So I do give opioids to older adults on a regular basis and just follow it closely. I do make a mental note when I'm taking care of an older adult with renal insufficiency to calculate their creatinine clearance because they may get into a little more trouble with morphine if they have renal insufficiency than a younger adult. Okay, moving on. It's the next night. Her surgery was delayed. She is still having 8 out of 10 pain. She's taking the oxycodone 5 milligrams every 4 hours. She's taking the scheduled Tylenol. You go see her. Her vital signs are stable. She is not delirious. She's alert. She looks uncomfortable. She says the oxycodone helps, but not enough. So what order would you write now? Would you add IV hydromorphone? Would you increase the oxycodone to 7.5 milligrams every 4 hours as needed? Would you change the oxycodone to a range dose of 5 to 15 milligrams every 4 hours? Or would you schedule OxyContin or long-acting oxycodone? Great. Okay. Again, people chose every choice. And I have to say, and I am not surprised at all, this happens every time I give this lecture. My best answer is actually B, increase oxycodone to 7.5 milligrams every 4 hours as needed. Most people chose C, which is a common order I see in the hospital all the time, but it is not the technically correct answer for this patient, and I will tell you why. So there's only a few things in this lecture. There's 2 things in this lecture, actually, that I suggest that you write down in your little book or on your phone or kind of put in your memory. The rest of it is things that you can look up, but these are things that I use all the time. And so the first one is this, the amount of opioid dose escalation. See the escalator. A patient is on opioids and they're having pain. How much do you increase the opioids? And the rule of thumb is 25 to 100%. So 25 to 50% to mild to moderate pain, 50 to 100% for moderate to severe pain. But we should not increase more than 100%. And that's why the common range dose of 5 to 15 every 4 hours as needed is actually not technically correct. Patients don't get into trouble too much because the nurses don't make that jump. But as the prescribing provider, it is our job to write an order that is always going to be correct, right? I'm always hearing about movement towards like disallowing that kind of order. It hasn't quite happened yet, but we shouldn't be writing such a big range. 5 to 10 is okay. On the other end, we don't want to increase less than 25%. And that comes into play if you have a patient on the oncology service and they're on 50 milligrams of morphine and you're like, gosh, that's so much. I'm going to give them 55 or 60. And they just won't really notice that because they are opioid tolerant. You can increase short-acting oral opioids with every dose. So if you are starting out and you want to control people mostly with orals, which is generally a good idea because the IV doesn't last very long, you can go see them, see how it's going, and increase the next dose. We don't do a lot of long-acting opioids in the hospital these days, but if you don't want to increase the long-acting oral opioids more than every 24 hours, and you don't want to increase the fentanyl patch more than every 72. What about the OxyContin in this question? So scheduled pain medicines are often appropriate for constant severe pain, but I don't start the long-acting oral opioids until A, the pain is relatively well controlled, and B, unless we're sure that this patient can take them as an outpatient or taper them down. So instead of that, I'll use scheduled short-acting opioids. If somebody has cancer pain, and we'll talk about this in a minute, I will prescribe oxycodone 10 milligrams every 4 hours, scheduled, hold for sedation, patient may refuse. So the answer is 7.5 milligrams every 4 hours as needed for pain. Great question. So, and there's not a ton of science here. Most people with only mild renal insufficiency. So the question was whether I recommend Q4 hour as needed to Q6 hour for oxycodone in this scenario. And I do for her, if she had worse renal function, and I can't give you a number, I might give it Q6, but especially because it's PRN, right? And so she can ask for it later if she needs it later. Q4 should be safe. Great question. Yes, a range 2.5 to 5 is fine. If the question is what is a range, somebody can help you like type the order in. You type in 2.5 to 5, and so that's an option. Correct. The patient or the nurse picks whether they get the 2.5 or the 5. And in my experience, it's usually a conversation between the patient and the nurse.
I think we didn't get to see that question. Was the question just how to
Oh, the question was, oh, sorry, that was a direct message. Somebody asked, what's a range 2.5 to 5 milligrams order? Is it an option to have 2.5 and 5? So a range order is an option to have either 2.5 milligrams of oxycodone or 5 milligrams of oxycodone. And the nurse and the patient together choose which dose they're going to get. All right. 2 nights later, we're moving right along. Her surgery is scheduled for tomorrow, and this is a totally artificial situation. But the nurse calls to say she's strictly NPO. She can't even take pills for some reason. Can she have some IV medications? So the pain has been relatively well controlled on oxycodone, 7.5 milligrams every 4 hours as needed. You decide to stop the oxycodone and start IV hydromorphone. So I'm going to talk about opioid conversion, meaning you're on one opioid, oxycodone, and you're changing to another, for example, hydromorphone. So you look in Epic and you add up what was the total opioid use in the past 24 hours. You use an opioid conversion chart or website or app. Gosh, I'm so old that I said chart. Nobody really even uses that much. I use the app that is right there. It's a reliable app. It's easy to use. The key point here is to decrease the equa-analgesic dose by 30% to account for incomplete cross tolerance. So if you've been taking oxycodone for more than a day or two, your opioid receptors are used to the oxycodone. If you have noticed your patient the first day of taking an opioid or a new opioid will have more side effects. They'll be a little more sleepy. They'll be a little more nauseous. If they look safe and you keep going with that dose, the next day they're like, oh gosh, I feel so much better and I'm not sleepy or nauseous anymore. So when we change somebody to a different opioid, we don't want them to go through that whole process again if we can help it. So we decrease by 25 or 30% to account for incomplete cross tolerance. And this app and most apps that you would use will do that automatically for you, but you should be aware of it. Then you come up with a 24-hour dose and prescribe that dose. I have a chart here. It's just for conceptualizing this, that opioids have different potencies. And so when we do opioid conversion, we're just looking for an equa-analgesic or equivalent dose. A thing to kind of remember is that hydromorphone and fentanyl, which is dosed in micrograms that I don't have on this chart, are more potent. It doesn't mean necessarily they're more dangerous. You shouldn't use them. They're just more potent. So you should have in your head an idea of the relative potency. And when you're going from something else to hydromorphone IV, that should be a smaller number. The second thing that you might consider writing in your phone or your little book or putting in your head is that a milligram of IV morphine is roughly equivalent to 3 milligrams of oral morphine, or 2 milligrams of oral oxycodone, or 0.2 milligrams of IV hydromorphone. And again, don't do the math in your head, right? Just to be able to kind of double check yourself and know what the numbers should come out to generally. And so I'm not going to go through this math, but here we're looking at the 24-hour use and then converting it. And say we're going to give hydromorphone IV every 2 hours as needed. A PCA would also be a good option here, which I'll talk about in a little bit. All right, new admission, moving right along. Mr. G, he has metastatic prostate cancer. He's on hormonal therapy. He is being admitted with increased pain, somnolence, and new renal failure with a creatinine of 3. And he's on acetaminophen, morphine, and some other meds. So he was kind of a typical SCCA patient, and he was being prescribed some long-acting morphine and some short-acting breakthrough morphine that he was taking a couple of doses of, but he's been having more pain and he's been more somnolent the past couple of days. You go see him, his vitals are stable, he's somnolent but arousable. So the teaching point here is opioids in renal insufficiency. So the best opioids in renal insufficiency are methadone and fentanyl, which is a bummer because methadone is very long acting and difficult to titrate, and fentanyl just comes in IV and in a lollipop, which costs $10, and in a patch. So, as you've already noticed, because so many of your patients have renal insufficiency on the wards, we use hydromorphone and oxycodone. Hydromorphone is preferred in dialysis patients. If you use oxycodone in a dialysis patient on a regular basis, it'll build up and then it'll be all cleared out of their system with dialysis. I do not use long-acting oxycodone in patients with significant renal insufficiency, and I don't use morphine in patients with significant renal insufficiency. In terms of liver failure, fentanyl, again, also the technically correct answer, but luckily hydromorphone and oxycodone are also totally fine. Methadone should be used with caution in patients with liver failure, and you should have an expert help you out. So as a summary, we should avoid both morphine and long-acting oxycodone in significant renal and liver failure. We should avoid methadone in liver failure. Fentanyl is totally optimal in both, and you can, generally you would consult chronic pain or palliative care if people needed a lot of fentanyl. But on a daily basis on the wards, you guys are probably already using hydromorphone and oxycodone with caution, with that Q6-hour dosing interval that we talked about. And again, hydromorphone preferred in dialysis patients. All right. Couple more words on opioid choice. I'm not saying don't use morphine. It's a really good first-line agent if people's liver and kidneys are working pretty well. It comes in a lot of formulations. It is cost-effective for patients. Sometimes I've found that oxycodone, depending on people's insurance, is shockingly expensive at the last minute. I don't use codeine. It mostly makes people throw up and does not really work. I don't personally use meperidine or Demerol. It has a risk of seizures and delirium. If you are on the HEMONC service, you may have noticed that it is still used for rigors in patients, for example, with neutropenic fever. I looked this up and I didn't actually find a benefit of Demerol rather than morphine. I don't treat rigors on a regular basis. I would probably personally choose morphine. It is okay if your patient doesn't have renal failure and your oncology team is saying try some Demerol, that's okay. I wouldn't otherwise use it on a regular basis. I don't use tramadol. It's a dirty mixed drug. It has its place in the outpatient setting, but because I'm an inpatient doctor, I don't find it safer. I don't find it very effective, and so I don't use that in the inpatient setting. All right. So back to Mr. G. In this case, he's having renal failure for whatever reason, and his morphine is accumulating. So what I would do is I would not give him further morphine. If he wakes up with pain, I would give him a little bit of IV hydromorphone. When he wakes up all the way, I would give him oxycodone or hydromorphone. And then I might consider a hydromorphone or fentanyl PCA when he's alert enough to press the button to look at his needs to discharge him on oxycodone or hydromorphone. This is a patient with malignant pain. This is a patient with who's going to have constant pain for some period of time. My overall protocol for these folks is just a little bit different from somebody who has surgical pain that I think is probably going to need to discharge on significant opioids. In this patient, I would start scheduled short-acting oral opioid every 3 to 6 hours, usually every 4. I would then order as needed oral and IV opioid for breakthrough at 10% of the 24-hour dose. So if they're getting 100 milligrams of morphine in a day, they would get a 10 milligram oral as needed morphine dose. Every 24 hours, I would change the scheduled dose if they need it. If dose de-escalation is similar to dose escalation, if people are a little bit too sedated, I go down, usually by 25%. Once the pain is controlled, then if a patient is appropriate for long-acting pain medication, then I would convert them. Somebody asked if there's any benefit to IV morphine over IV hydromorphone for certain patients. There is not really. If you think that you're going to send somebody out on oral morphine, they don't have liver and renal insufficiency, then I would probably start with IV morphine. All right. So I had mentioned that a PCA might be a good option for this patient. I'm going to talk a little bit about a PCA. So a PCA stands for patient-controlled analgesia. It is a safe method of delivering a relatively constant, very low dose of opioids. It is appropriate for a patient who is alert, who has pain that's severely impacting their function, when I don't know exactly how much to give them, because if I knew exactly how much to give them, I would give them that amount. And also in patients who would benefit from control of dosing, somebody who is otherwise appropriate and also says, oh my gosh, like I'm in so much pain when I'm waiting for the nurse to come and bring me this dose. So there is what they call an incremental or a lockout dose. That is the dose that they get when they press that button. There is what is called the clinician bolus, and the clinician in this case is the nurse. And so they press the button every so often and they get pain medication. If they are having too much pain, they can call the nurse, and the nurse can come give an additional dose every couple of hours from the pump. On top of that, they may have either a continuous infusion or another basal opioid like their long-acting morphine if they were on that before. So you all can order a PCA, and what you can order is a primary service PCA order set. So it's not what the pain service or palliative care can order. And it is a low dose of hydromorphone or morphine without a continuous infusion. If somebody needs, so say it's your cancer patient and they're on long-acting morphine and you want to put them on a PCA and you think that the dose that's available to you is sufficient, that's a quick call to pain service or palliative care to continue their home basal opioids. If you are doing this, and I'm skipping around in the bullet points, if you are starting somebody on a primary service PCA who's been on opioids at home, just do the math to make sure that what they're able to get from pressing the button is going to be at least as much as they were getting at home. Otherwise, you're going to need to call pain service or palliative care for a higher dose PCA. If you are taking care of a patient who is on a PCA and you are called to say, gee, their pain is not controlled, the first question to the nurse as you're like walking over there should be whether they have used their clinician bolus. Every once in a while, a nurse will forget that they can do that, and they will do that, and then the problem will be basically solved. Be careful with the sedating symptom meds. They are part of the order set, but definitely in older adults and in more frail patients that are at risk for over sedation, like especially my oncology patients with brain mets, I will usually try to avoid those if I can. All right, moving right along. New patient. This gentleman is 50 years old and he's admitted with cellulitis. He's hypertensive and he's complaining of pain and nausea, and he's asking for methadone. So he's a watcher. He has a history of opioid use disorder. He's taking fentanyl or other agents on the street. This is not somebody who's on a methadone maintenance program or Suboxone, and he has cellulitis, and there's his meds. So the first point is to have a little bit of a sense of what opioid withdrawal looks like and when you can expect it. So I have the signs and symptoms up there. The peak time of opioid withdrawal is 36 to 72 hours for heroin and longer for methadone. Unfortunately, since fentanyl is most of what's out there these days, it's all a little bit unpredictable, but withdrawal in general may start after 48 hours or more and last a little while. You want to ask about what else they're using, whether they've taken methadone or Suboxone in the past, and what their wishes are, if they know right when they come in, about starting some medication-assisted therapy for opioid use disorder. So he's not taking any medications for opioid use disorder. He's not using any other agents. He's in withdrawal. He says he gets 80 milligrams of methadone a day when he's in the hospital, and you don't have any way to verify this. So what order would you write? Would you give him 80 milligrams of methadone? Would you give him 20 milligrams of methadone? Would you give him oxycodone as needed? Or would you give him clonidine, hydroxyzine, and phenergan and try to avoid opioids altogether? Oh, great. Okay, so the majority of you chose what I also think is the best answer, which is methadone, every 20 milligrams every day, hold for sedation. Somebody did pick all of the other answers, but that's great. And I will talk about that a little bit more. All right. So conceptually, the goal in inpatients with opioid use disorder is to prevent or treat withdrawal so that they can get good medical care, right? This sounds funny to say out loud, but I think deep down, sometimes we feel like, oh gosh, this person has a serious problem and I don't want to give them more opioids because could make it worse, right? But that's not the case, right? They have a long-standing serious problem that they can get treatment for. But what we do in the hospital is generally not going to make the underlying opioid disorder better or worse. What we can do is really hurt their medical care if we let them withdraw, because often they'll leave, right? We do want to initiate substance use treatment referral, inpatient or outpatient. We finally have a addiction medicine consultation service at Montlake as well as Harborview, which is great. And we want to discharge with a naloxone prescription if they don't have one. There is a great set of guidelines in Occam that goes through this in more detail. So my usual practice for many years, and this is, I've confirmed this with Dr. Klein, who's our expert, is to start methadone 20 milligrams PO daily. When I start it, I'll come back within a couple of hours. If they're really still having severe symptoms, I will give them up to an additional 10 milligrams. I don't give more than 30 milligrams on day one. And then over time, every couple of days, I'll increase by 5 to 10 milligrams. On top of the methadone, if the patient is having severe pain, say this guy had a large abscess drained and he has a big open wound, I would also give some short-acting opioids. So I would give methadone 20 milligrams every day, and then I would give oxycodone 10 milligrams every 4 hours as needed for pain. All right. Suboxone is also an option. I believe there is some additional training in Suboxone that you guys will get during the year. I still reach for methadone when people first come in because they don't have to be withdrawing all the way you do to induce people on Suboxone. And it is a little bit easier to add the other agents on top of the methadone, but Suboxone is also totally appropriate to use. All right. If you prescribe methadone, or if you have a patient that comes in and they're on methadone, a light bulb should go on above your head, like in a cartoon, that says drug interactions, right? You don't have to have them memorized, but you just need to know that there are a lot of drug interactions with methadone, and that you should either look them up or talk to your pharmacist, because commonly used medications in the hospital can either precipitate withdrawal or cause the methadone level to increase. All right, moving along. Our new patient, unfortunately, has new 6 out of 10 suprapubic pain. She's getting morphine and Tylenol, but it is not helping. So she is stable. She is a 41-year-old woman with metastatic breast cancer. She has it in her brain, her bones, and she's here for pain control and XRT, and the team is titrating up her morphine, and those are her meds. So last poll, she's again on morphine, having increased suprapubic pain. Okay, so most people chose the best answer here, which is bladder scan. She most likely has urinary retention, which can happen even if I had made it a 86-year-old man with prostate cancer. It might have leapt to your brain, but women can also get urinary retention from opioids. This is the teaching point here is opioid side effects. And urinary retention is honestly one that we sometimes don't think about as often as we should, which is why I bring it up. And if you're called for any kind of new pain in the belly or in the suprapubic area in a patient on significant opioids, you should think of that and go to the bedside and examine them and look at their eyes and O's and mash down on their bladder and see if that might be the issue. And then consider bladder scan, Foley, and then the treatment is Foley or straight cath, and then considering a little decrease in the opioids. Constipation, people always think about. If you're called for nausea in a patient who's on opioids, it may be from the opioids directly, or it may be because they're constipated. So think about that too. Confusion, as we talked about earlier, it may be from opioids, but you want to think about other underlying causes. I was called on palliative care last week for somebody who had new delirium after an increase in his morphine. But when I went and saw him, he was confused, but he was not at all somnolent. And he also had an increasing white count and some other suggestions that his delirium was related maybe to a new infection and not to his morphine. So we actually kept the morphine the same while we looked into his other reasons for his delirium. Two rarer opioid side effects that you might see on the oncology service if your patient is on high dose opioids, which is myoclonus. It is usually in somebody with renal insufficiency who's on hydromorphone. Even though hydromorphone is okay in renal insufficiency, it will build up at the higher doses. And then something called hyperalgesia syndrome, and you won't forget this once you've seen it, somebody where you're giving them more opioids and they start to have more pain and they have a lot of sensitivity, like they're going to want to pull off their hospital wristband because it's hurting them. And those are reasons to be consulting palliative care or chronic pain, or to make them aware if they were the ones prescribing, if you see those side effects when you're examining your patient. So we would bladder scan her. All right. 3 days later, same patient, we've been titrating up her morphine, and the nurse calls you and says, gosh, I can't wake her up, and she's breathing about 6. She's full code. The rest of her vitals, thankfully, are stable. Her respiratory rate is 8 when you get there, and you do a sternal rub, and she kind of like wakes up and goes back to sleep. So this is kind of mean because we don't have you memorize a bunch of doses. But if you've experienced this, would you give 0.4 of naloxone, which is the whole vial? Would you give her 0.04 of naloxone, or would you start a naloxone drip? Okay, yeah, this is a tricky question. And the majority of you did pick the smaller dose, but just by a little bit. So the correct answer is the 0.04. And the stat nurses generally would know this and would help you out. The amp of naloxone, 0.4 milligrams, should be diluted in 10 mLs of saline and given 0.04 every 5 minutes. In the patient that I have, the picture that I have painted to you, which is a patient who has a slow respiratory rate and is hard to wake up, but her vital signs are otherwise stable, right? If it's a code, you could give the whole amount, right? But for a patient like this, where you're giving the naloxone just for them being sleepy and a little bit of a slow respiratory rate, you can go a little bit slower. We give naloxone to keep people safe, but it gives them withdrawal and pain, and we don't want to give more than we have to unless it's a truly emergent situation. All right. Poor Mr. G is still in the hospital 10 days later. He has, again, metastatic prostate cancer, renal insufficiency. He's on comfort care. He's going home with hospice. The nurse calls you. He was getting IV hydromorphone, and he just lost his IV. He's having pain. He's a little bit sleepy, but he's definitely arousable. And the nurse is worried about whether he can swallow pills. So do you put in a central line and start a drip? Do you order a PIC and start a fentanyl PCA? Do you place a fentanyl patch? Or do you start scheduled liquid hydromorphone with breakthrough? Great. Okay. So most of you chose what I think is the best answer here, which is starting scheduled liquid hydromorphone with some breakthrough as needed. So the teaching point here is that IV is not the only option if your patient can't swallow, and liquid oral opioids are a really good option. They're used widely around the world on hospice. A family member can squirt a little bit of concentrated morphine into somebody's mouth, even if they're not going to swallow it absolutely completely because it has buccal absorption. And so these are good things to know about, not only when your patient is on hospice or comfort care, but in other situations where your patient is having trouble swallowing, you might consider, probably with a pharmacist's help, a little bit of oral opioids. And then there's plenty liquid oral opioids. And there's plenty of options for antiemetics also. We've worked on the comfort care order set over the years. So the default should be the morphine. It's actually not the concentrate here, but it's the 2 milligram per ml solution. So for most patients, they're going to be getting 5 mLs of solution, and that's really not very much. Oh, good question, Connor. Did they taste very bad? I have not heard that complaint. They made us taste all the laxatives just a little bit in geriatrics fellowship, but they did not, for obvious reasons, make us taste the opioids, but I haven't had people complain about it. So start scheduled liquid hydromorphone with as needed for breakthrough. So if your patient is on comfort care, always use the standard order set. It's a pretty good order set that we change over the years, and there's a multidisciplinary team that works on it. It is a little bit confusing the first time you use it, so feel free to reach out to your senior, your attending, or to the palliative care service if they're involved. We generally should be starting with the liquid oral opioids as first-line treatment for both pain and dyspnea. If they have an IV, then by all means add some IV PRN breakthrough. If somebody has refractory pain, then switch to the drip, and that should be a common sign out in your comfort care patient doing well on X amount of liquid oral or IV. Go into the comfort care order set and transition to a drip if they have refractory pain. Benzodiazepines are helpful for anxiety and insomnia, and also if people are having pain and discomfort or dyspnea. So if you're covering a comfort care patient and you're called, I would max out. I would try some opioids first, once or twice, increase the dose, make sure they're getting it frequently enough. And then also during that process, give them a dose of the benzodiazepine that they should have on their order set. All right, that is wrapping. That is the last slide. Please remember that this is a team sport, and don't feel like you have to take care of your patients with pain all by yourself. Make sure you use your resources, your senior resident, your pharmacist, the pain service, the palliative care service. There are no badges in medicine for trying to figure it out all by yourself. And a small village has given me feedback on this slide set, which I've been giving since 2016. All right.
Thank you so much. That was incredibly helpful. That was a great review and overview. Any questions you guys have, feel free to ask or put them in the chat.
Dr. Merel, I did have one question about PCAs. One of the reasons you mentioned using it is to kind of get a sense for someone's 24-hour total opioid dose. I'm also wondering, just like transitioning away from PCAs generally, not necessarily in that situation, but in any situation.
Yeah, great question. It's actually just it's just like transitioning to and from other opioids. So the thing with the PCA is that you need to make sure you're getting the correct 24-hour dose. And so if somebody was on oral morphine, you would just be able to look in Epic. And ideally, you could just look in Epic or CPRS or ORCA or whatever they're using at the VA for somebody's PCA usage. But it's just a hard thing for nursing to keep up with in terms of making sure they put that in every shift. So if I have a patient who's on a PCA, I go to the bedside and I interrogate the pump. And the nurses should actually know how to do this. Sometimes if it's a newer nurse, they'll ask for help, but the nurse can help you do that. If your patient is being followed by palliative care or pain service, they can help you. And then it's really pretty straightforward after that. If they're on a morphine PCA and they're going to oral morphine, you just make that conversion from IV to oral and you divide it up. If they're going from morphine to hydromorphone, then you would need to do the decrease for incomplete cross tolerance. Oh gosh, really good question from Yvonne in the chat. Buprenorphine for pain in some patients. And I have to say, I am just not doing this a lot because I don't have an outpatient practice. I haven't seen that much. I haven't really seen buprenorphine used for pain in the inpatient setting. Emily, feel free to chime in if this is somebody that something that you've seen at the VA. I do. It is something that I've considered and referred people out for. Somebody who has who's on chronic opioids, and for whatever reason, we don't think that staying on traditional opioids is a good idea. So yeah, so buprenorphine for pain, good thing to investigate. I don't have a lot of experience with that. Emily, do they do an evaluation? How does the evaluation come? Does it come in their email?
Yeah, we're actively working on that. So as of now, I don't think we have a eval going out, but we are going to kind of start implementing that.
Okay.
Yeah.
All right.
Thanks, you guys. I think people are logging off. Thanks for coming. We'll see you again next week. And we only have 2 more, so things are going fast.
Emily, can you stand for a minute?
Yeah, of course. Okay, we're down to just Connor.
So
I'm going to stop recording. Hold on.
Yeah.